Good afternoon, everyone. My name is Nikolaos Mansolas, and I'm a resident doctor working in intensive care in the Newcastle upon Tyne NHS Foundation Trust in England. And it's my pleasure to be speaking at EDM 2026. For my presentation, I'll be talking to you about a recent case report that myself and Dr. Nesbitt, working in also in Newcastle, published in JMCR, which was entitled Recurrent Ventricular Asystole During Octreotide Infusion in a Patient with a Pancreatic Neuroendocrine Tumour. Now, incidence of neuroendocrine tumours is rising globally, and therefore neuroendocrine tumour surgery with a curative intent is becoming more and more common. When they are manipulated intraoperatively, neuroendocrine tumours can release vasoactive substances and hormones, including one of the substances, including serotonin. These substances can lead to carcinoid syndrome and, in extreme cases, carcinoid crisis. Carcinoid crisis has important consequences intraoperatively from an anaesthetic point of view and from an intensivist's point of view, given the potential for hemodynamic instability, as well as a possible ventilatory compromise due to bronchospasm. As prophylaxis against carcinoid crisis, patients who are undergoing surgery for excision of neuroendocrine tumours are normally preoperatively established on infusions of somatostatin analogues, intravenous infusions. And octreotide is the most commonly used somatostatin analogue in our hospital trust in England, and I think across the whole of the UK. So in our case report, we describe the case of a 62-year-old gentleman who was undergoing an elective pancreatectomy and splenectomy for a pancreatic neuroendocrine tumour, which was identified on computerized tomography. Of note, the patient had a significant past medical history of congenital partial anomalous venous drainage, with the right superior pulmonary vein draining into their superior vena cava. These vessels are circled on the diagram on the right of the screen. This anomaly essentially leads to oxygenated blood from the right superior pulmonary vein draining into the deoxygenated blood of the superior vena cava. This congenital defect was identified in the patient's 40s and repaired by the cardiothoracic team. This was by rebaffling of the vessels and drainage of the superior pulmonary vein into the left atrium. They also had an implanted loop recorder, which had since been explanted. Type 2 diabetes, hypertension, and prostate cancer, which had been treated with radical radiotherapy. So the patient underwent their pancreatectomy and splenectomy with an uneventful intraoperative course. There were no complications intraoperatively, and they were extubated postoperatively in theatre recovery, and then admitted onto our high dependency unit as a level 2 patient. They had pre-operatively on induction been loaded on octreotide intravenously and then established on an octreotide infusion at a rate of 50 micrograms an hour. And this was continued on high dependency postoperatively, as per the surgical plan. Now, 10 hours following the commencement of the octreotide infusion, the patient sustained approximately a 30-second period of ventricular standstill, which can be seen on the telemetry recordings that are on the right of the screen. And this corresponded with a state of low cardiac output, which we can see on the readings of the arterial blood pressure, which is the bottom line on each of the 4 recordings. The state of low cardiac output was accompanied by a loss of consciousness, secondary to severe hypotension. The patient had a return of spontaneous circulation, which occurred at 30 seconds before any of the intensivist medical team could arrive at their bedside, and correlated with a complete return of normal sinus rhythm and a normal blood pressure, which wasn't supported with any vasopressors or inotropes. The patient became conscious and reported feeling quite nauseous, nauseated, and generally quite unwell. Extensive investigations were undertaken following this first episode, including an extended electrolyte panel, which was all normal, 12-lead ECG, chest x-ray, and a review of their medications. Their chest x-ray and extended electrolytes were found to be unremarkable. 12-lead ECG revealed no dynamic changes compared to the previous ECG, which was completed pre-operatively. And a review of their medication list revealed that no medications were being administered, which are commonly associated with bradycardias, conduction abnormalities, or hypotension. The patient then suffered a further 2 similar episodes, one of 30 seconds and one of 10 seconds, which were both completely followed by a complete spontaneous return to spontaneous circulation. Cardiology were consulted at that point and conducted a face-to-face patient review and a review of the telemetry recordings, and they suggested ongoing monitoring and consideration of an isoprenaline infusion in the event of repeated episodes. Now, this was around the time of morning handover, and following repeated episodes of ventricular standstill, the day team consulted literature on octreotide, and octreotide was considered a potential medication that could be contributing to these episodes. The literature regarding the cardiac side effects of somatostatin analogues was consulted, and the British National Formulary noted that a known side effect of octreotide and somatostatin analogues in general is sinus bradycardia and arrhythmias. And a small number of case reports were noted whereby patients suffered severe sinus bradycardia, complete heart block, and asystolic events were also had been associated occasionally with administration of intravenous octreotide. Octreotide administration at this point was stopped, and the patient had no further episodes of ventricular standstill and had no further requirement for any hemodynamic support throughout the rest of their HDU admission. They were subsequently, following a period of monitoring, discharged onto one of the surgical wards, and from then on they have since been discharged from hospital and are back to their normal pre-hospital baseline, functional baseline. Now, conclusive evidence on the mechanisms by which octreotide and somatostatin analogues exert their effects on cardiac conduction remain largely unknown, and the majority of research has been in vitro and in animal studies. Electrophysiological studies in humans are very few and use very small sample sizes. The main two studies utilizing sample sizes of 14 and 12 patients, respectively. The evidence available demonstrates that somatostatin analogues have a negative chronotropic and negative inotropic effect on the myocardium, with mechanisms including inhibition of myocardial calcium channels, L-type calcium, voltage-gated L-type channels in the sinoatrial node, activation of G-protein coupled inward rectifier potassium channels, and modulation of autonomic release, so enhancement of parasympathetic tone, and inhibition of catecholamine release. So what have we learned from this case report, and what can we learn? Somatostatin analogues are generally very well tolerated, but physicians who are looking after patients perioperatively, in the perioperative setting, need to be aware of the side effects which somatostatin analogues can have on cardiac conduction via their negative inotropy and chronotropy. Previous cardiac surgery may increase the risk of cardiac conduction abnormalities in those patients who are receiving intravenous somatostatin analogues, and further investigation as to the risk profiles that increase the risk of cardiac conduction abnormalities with intravenous somatostatin analogues is required. And patients with a previous history of cardiac surgery may benefit from enhanced cardiac monitoring while they are on intravenous somatostatin analogues, with measures such as invasive blood pressure monitoring and cardiac telemetry. Here are the references that I used in my presentation, and I hope you found it interesting, and thank you very much for listening. Cheers.